What's newly proposed for Medicare Shared Savings Program accountable care organizations? That's MSSP ACOs.
Thanks, Kyle. Good question. First, they're proposing an update to attribution eligibility. Not attribution itself, but what patients that are seen by ACO providers are eligible for attribution. This will change the denominator that will determine whether a provider is a qualified participant or a partially qualified participant. So they're proposing to expand the filter from at least one E&M code. So all patients who've had a visit where there's been an E&M code charged in the applicable year to any service code whatsoever. Now, attribution determination would still be unchanged. There's a prospective attribution potential. Then there's the high probability of primary care codes, particularly annual wellness checks. And then for anyone who doesn't place with one of those techniques, the preponderance of care or plurality of care, measure. So you'd still you could get some new patients attributed through this, but mostly it would change the denominator, not the numerator. So I'm not sure that this will be desirable. So if you don't want to see that change, make your comment. I think this is up in the air whether they'll accept it or not. So we'll carry on from there. Next is a continued refusal, important, to postpone sunset of the web interface. So that's still on target, that this 2024 performance year is the last year that the web interface is eligible as a collection technique to give your quality metrics to Medicare. They're proposing to expand the APP measure set to what they're calling the APP plus measure set. Now, I was expecting this to happen, but this is a little earlier than I expected to see it. So as of 2025, they'd like to add measures to that APP measure set. Now, they're proposing something that we expect to have some longevity. First, they want to align the APP measure set with what's called the Adult Universal Foundation measure set. 3 submittable measures and 2 administrative claims population health measures that Medicare calculates. One of those is not a universal foundation measure, although they don't propose to remove that. They're proposing to add the other 5 universal foundation measures to the list. For 2025, they're proposing to add breast cancer screening and colorectal cancer screening. That's measures 112 and 113 to the APP requirements. For 2026, they propose to layer in substance use disorder treatment, measure 305. And for 2028, skipping 2027, in 2028, adding screening for social drivers of health and adult immunization status, measures 487 and 493. They're also proposing to drop the MIPS CQM collection method from the APP starting in 2025. So as of 2025, only permit eCQMs or Medicare CQMs as submission methods or data collection methods. Now, their intention with Medicare CQMs is that they are still a temporary collection type, but no time frame is proposed for its sunset. And if they do finalize this change, I would expect that would keep that around a lot longer until ACOs are confident universally that they can switch to eCQMs. Now, I think there are a lot of good reasons not to do that, and a lot of good reasons why you might comment against it, and I'm certainly going to comment against it. Prominent among those disadvantages, I think it will significantly increase the cost of reporting. It'll hurt disproportionately low revenue ACOs. That paradoxically, Medicare is quite pleased that low revenue ACOs generally generate more shared savings than high revenue ACOs. it's likely to be an exclusionary factor to push many, particularly small practices, out of ACOs and accelerate the consolidation of health practices, a trend that has not been seen to be more likely to increase the value in care, but more likely to increase the cost of care. I plan to dig into this more specifically at a future episode, so keep watch for that. And whether you agree with me or not, I recommend that you post your comments about this to Medicare through the Federal Register. Now, next proposal for Medicare CQMs, they propose that benchmarks for the first 2 years, instead of being performance year benchmarks, that they use flat benchmarks. So a pre-published set of benchmarks, and the proposal is in the proposed rule that tells you what your score is going to be at any particular performance level. Until 2 years after their introduction, there's enough data to set historical benchmarks. They're proposing 2 incentives for the use of ECQMs. One is to continue the favorable quality standard, and that is an indefinite extension. So the language will continue it until they end it. I think the current favorable quality standard is set to end after this submission year, or this performance year, excuse me. It's for MSSPs who submit the APP as ECQMs. The proposed rule includes language that extends it indefinitely. You meet the quality standard, collecting all of your shared savings if you submit ECQMs. All measures are submitted meeting data completeness and case minimum criteria. One outcome measures scores at least 10 points, and one other outcome measure scores at least 40. They're also proposing to add a complex organization adjustment bonus. That's any APM that submits ECQMs. Add 1 measure achievement point for each ECQM submitted. So an interesting set. I don't see any drawback from accepting these, or any reason that Medicare wouldn't make them final. So certainly think about it yourself and submit your comments to Medicare on all of this.